So I think over to Dr. ANAND SUBRAMANYAM. We'll start with you.
Good afternoon, friends. At the onset, I'd like to apologize and state that Dr. Rajiv Raman has been called for judge duties at the Colonel Rangachari Award session, so he's unable to attend this. So all his slides I shall be presenting. So excuse me if I've missed out a few things. So what the topic is treatment for PDR. I'm going to talk on panretinal photocoagulation. I'm for that. So we have all seen such patients, 63-year-old gentleman with PRP done 4 years back with just one more additional session of PRP done. And over the period of years, you have witnessed that the retina becomes like how we can see on the right hand side after 8 to 9 years of PRP. So photocoagulation and PRP for PDR, how does it fit with us? So this is the diabetic retinopathy study research group, and these are the numbers. So all these things are familiar to us. We are just reiterating all these things because we want to say that PRP is better. And what about long-term effects? We have numerous studies which says that after many years also, the stability of the eye is very sound. 84% retain visual acuity of 20/40 or better after PRP. What about visual impairment in patients with PDR? So this is ANAND's own study where Dr. Rajiv Raman has been the chief person in that, where they have seen what we have just said, that it holds true for Indian eyes also. And do we need anything further after doing PRP? So the need for vitreous surgery is also very less after doing a thorough PRP. So PRP is robust. We have been doing it for a long time, and now more than 3 decades have passed after treating patients with PDR. So do we need to change? So change is inevitable. So why do we need to change? For better anatomical outcome, better functional outcome, less adverse effects, less progression of disease, or is it more economical? So we shall discuss all these things one by one. So can anti-VEGF achieve these things? If we could, then maybe we can shift. But let us see Protocol S and Clarity trials. What do they say? Anatomically, Protocol S says the percentage is the same. Clarity says anti-VEGF has 30% more NV regression. Functionally, similar visual benefits, similar field loss. Vitreous hemorrhage rates are also similar, but obviously less of macular edema with anti-VEGF. What about progression? Ischemia continues to progress in both. And costs. This was seen in US, but in India we know that we have to do PRP versus anti-VEGFs continuously. Anti-VEGFs are definitely going to be more costly. So the answer after all these things is a resounding no. So should we combine anti-VEGF with PRP? So that there are certain studies which have been completed and ongoing trials where they compare anti-VEGF along with PRP. So what are the concerns? If we say that we are going to inject the patients, almost 60% of the patients after 5 years did not come for follow-up. And the outcomes are quite bad because patient has poor vision with more TRD, more NVIs. So if patient is had a course of PRP and if they miss a few of the injections, still it is tolerable. You don't get such massive regression or flare-ups. So as of today, PRP is the mainstay of management of PDR. It is a time-tested modality. Compared to anti-VEGF, it is safer, good efficacy, and economical. Thank you.
Thanks for that talk, Dr.